So, we're going to talk today about ways that we can apply clinical situations in order to help us to learn anatomy a little bit better. And the reason that we're going to do this is because we are going to progress throughout the rest of the term, taking a look at these clinical application questions for a variety of different reasons. One is that it just makes it a little bit more exciting instead of just straight memorization of what we tend to need to know for anatomy. It puts it into like a problem solving sort of a scenario. And so we're going to build upon this as we go out throughout the rest of the term. So, whenever we come upon an injured person, we need a way to be able to evaluate all different professions that we have in the medical field, need a way to evaluate these injuries. Now, there's a variety of different ways that we can do that. We're going to show you right here what an athletic trainer uses, but it's same in the field of nursing, EMT, physical therapy, all these different fields. They just might have slightly different words associated with this type of an evaluation. But what athletic trainers tend to use is the acronym of HOPS. And HOPS, HOPS, stands for a few different things that we'll be gathering as we start to ask questions of somebody who is injured. So the H stands for history. And this is when we can gather information about what happened during the event. What was it that caused this injury to happen? And also just pertinent past history, finding out about the person themselves. This is also when we can start asking questions as far as things that hurt, things that make it feel better, how much is the pain, at getting them to rank it on a score of 1 to 10 is always a good way to be able to do that. But this is all them reporting things to you. So this is part of their history that you are gathering. We also have observation, which are looking strictly at signs of what we can see. Whereas history was gathering a lot of information about symptoms, which are things that the person might be feeling, the observations are looking at signs, things that we can clinically see with our eyes. We can see limps, we can see deformities, we can see discoloration. Right? Those are our different observations that we might have. Then the P stands for palpation, and that is when we actually touch and feel the injury to find out what's happening. So we can actually identify where it hurts specifically because we'll be looking for that tenderness in those areas, or if there's deformities that we can feel but not necessarily be able to see that we saw in the observation, but by touching them, we can actually tell that there is deformation there. So that's palpation is when we are physically touching someone. And then there's a variety of different specialized tests that we can run, which usually revolve around range of motion testing to find out what might be causing the issue. And we're going to take the specialized testing and dive a little bit deeper to explore it. Before we do that, though, let's try to categorize some of this information using the HOPS system. So if we see that the clinician is seeing a patient walk with a limp, how would we categorize that as far as the HOPS system? Would it be history, observation, palpation, or specialized test? Well, hopefully you're coming up that it is an observation, right? Seeing them walk with a limp. How about if the patient reports point tenderness over the fibular head during physical examination? So physically touching the other person and they're reporting that there's point tenderness in one specific spot, that's going to be our palpations information that we have. And then what if we receive information that no pain is experienced during active range of motion testing? Well, that would be one of those specialized tests. So that's the S in HOPS. So let's talk about these specific range of motion special tests to help us to identify injured tissue. So specifically the ranges of motion we're going to be testing are active, passive, and resisted ranges of motion. And we're going to demonstrate what this is. Now, I do want to put a disclaimer in here is that we are not treating or we are not teaching you how to thoroughly assess and treat people who are injured. This is just using this as a paradigm to help us to understand how anatomy works. So, we're going to start off with active range of motion. Active range of motion is when the person is physically moving their body however you describe for them to move it in a concentric motion that we have. Passive is when we move it for them, and resisted is when they are trying to move, but we resist against that action. So let's take a look at a video demonstration. So here instructions are to flex that elbow, and you can see he moved and flexed that elbow. Next is passive. So the clinician would then passively move while he is relaxed. Last is the resisted, in which he's contracting against the clinician's hand while she is resisting it. So, those are examples of active, passive, and resisted ranges of motion. So let's just do a little short-term recall and see if you can figure this out and which it is. So if you are to flex your right elbow to 90 degrees, what would that be an example of? Active, passive, or resisted? Well, hopefully you're coming up with that. That is, in fact, active range of motion. Now, if you have your partner flex your right elbow to 90 degrees and you are completely relaxed, so if you have somebody around you while you're watching this video and you say, hey, can you flex my elbow to 90 degrees? While you stay completely relaxed, this would give you the example of passive range of motion. And then lastly, if you have your partner try to flex your elbow while you're resisting against them, or vice versa, without moving your arm, this is like an isometric type of a movement. And this is resisted range of motion testing that we have. And what it's going to be able to allow us to do as we move forward in class is to be able to analyze questions such as this in order to learn anatomy. So, a basketball player injured their shoulder during a rebound. They come to you complaining and requesting a diagnosis. You determine that the injured structure is a muscle. The athlete is weak during active and resisted shoulder adduction and shoulder flexion, but they are strong during active and resisted shoulder medial rotation. Based on this information, which of the following is the injured muscle? So, by looking at these different range of motion tests results that we have here after performing it, it would give us an indication of what we needed to be looking for to find out which muscle would be the one involved. We would be looking for the muscle that contributes during active and resisted shoulder adduction and flexion, but that does not contribute to active and resisted shoulder medial rotation. So we can now use this information to start narrowing down which muscles contribute to shoulder adduction and flexion, but do not contribute to medial rotation. And by looking at those results and determining that muscle, could know which muscle is the one that's actually injured. And we can use this framework to study anatomy more closely and do a problem solving paradigm to make it more fascinating to learn anatomy instead of just strict memorization. And it makes it more clinically based, which a lot of us are going into a field that is going to need some kind of a clinical basis. Please remember, we are not actually teaching you how to do these things. It is a framework and what we are going to be using for learning. Here's another example question we have. An injured worker comes to you for an assessment of their arm. Your assessment reveals active elbow flexion is weak and painful. Passive elbow extension is painful, and resisted elbow flexion is weak and painful. So, which of the following is likely injured based on this information only? And then it would give the different types of muscles or nerves or ligaments for us to be able to determine which it is. But this is just showing you a little sample of what we're going to get into. But first, we've got to point out a few premises that we have about this particular activity and for the rest of class. I need you to realize that this is not a perfect world and injuries are not really this cut and dry in the real world, like what we'll be looking at in this class. However, we're using this as this framework in which to learn anatomy that makes it a little bit more fun in this problem solving way. So, but the assumptions that we are going to be making throughout the rest of the term is the first assumption: there is only one underlying injury. So, whenever we're dealing with clinical type questions like this in scenarios, we're going to assume that there's only one underlying injury and it's not multiple things that are injured. So, it'll be one muscle or one nerve or one ligament, not a combination of those things and not more than one of any of those things. Now, in reality, that doesn't really happen. Often you will get nerve damage as well as muscle damage, or ligament damage as well as muscle damage. So, but in this particular paradigm, we're going to assume there's only one underlying injury. Two, any isotonic contractions, so any contractions that have movement on them that are referenced are concentric contractions. So ones where the muscle is shortening when the 2 points of origin come together. So these are always going to be framed in the world of concentric contractions, not eccentric, not why the muscle is lengthening, but why the muscle is shortening during that contraction. And our third assumption is that we are only going to be referencing motor nerves when we are talking about nerve damage here, which means we are not addressing sensory nerves, in which if sensory nerves would be injured, you would also have pain associated with this. But this is a way for us to test and find out what nerves might be the ones that are damaged, that are causing issues with the movements that we are trying to perform. So these are our three assumptions that we have. There's only one underlying injury. Any contractions that we're talking about are referenced as concentric contractions. And we are only talking about motor nerves when we're talking about the nerve injury. So let's take a look at some range of motion testing and the findings we might have. And we're going to first go through this by tissue type, then we'll go back through it through findings and what we actually learned. So we're going to start off with muscles. Now remember, we have active, passive, and resisted range of motion. So here we are looking at the active range of motion when there is an injury to the muscle. And you can actually see right here, there's indication of an injury. You can see that little mark on his bicep right there. And we're going to take a look at what's happening. So when there's contraction of that bicep, and it's a concentric contraction as the elbow is coming up, you'll notice that it's inflamed and you see that redness start to turn, right? And you can see that there's pain associated with that during that active range of motion. It also will cause it to be more weak because there's damage to the muscle. The fibers are not as strong to be able to produce that movement. So with our concentric movements, yes, we will have pain in whatever movement that muscle is contributing to. And yes, there will be weakness that is associated with it. So that is for our active range of motions in our muscles. Now let's take a look at passive range of motion. So instead of them actively uh, producing that movement of elbow flexion, we're now going to do it passively, where the clinician is actually the one that is moving the elbow for them. So when we're doing it in this type of emotion, and what we can see is that when they are concentrically doing the motion of flexion, we're not seeing that pain. However, when it is flat, when it's in the opposite direction and it's actually extended instead of flexed, there is some pain that is associated with it. And you can see that by the little red markers right there, right? So there's no pain when it's being flexed, but in the opposite direction, we will actually see pain. So what does this mean? With the concentric movement, when there is passive range of motion testing on a muscle, whatever muscle movements that muscle contributes to, there will not be pain in the concentric movement. However, there will be pain on the lengthening in the reverse movement. So in this example, what we were looking here, we were testing flexion, and we did not see pain on that concentric movement. However, when we stretched that muscle as it was being lengthened back to its resting state, that's when the pain is felt. So it's on extension or that reverse movement. If this was an example of using abduction and adduction, right? Abduction, if there was pain with the muscle contraction on active range in motion, on abduction. With passive, you would not also get it if it was the muscle injury. You would not also get it on abduction, but as you were bringing it back and the length of the muscle was lengthening, you would have pain associated with it. So that's the reverse movement there. Now, with passive range of motion, we're not actually testing force at any point. So weakness doesn't really apply in this particular circumstance because you can never test weakness on passive range of motion on the muscles because you're not exhibiting any kind of a force whenever you are doing passive range of motion testing. So next we have resisted range of motion testing. And if it was a muscle that was injured, again, we're still looking here at the bicep. And we are doing resisted range of motion in which we're resisting them from being able to contribute to it. On the concentric motion, yes, there would be pain, but we would also see weakness. So this is very similar to what we saw right here. You'll notice, so when there's resisted going up with that flexion, yes, there was pain associated. Right here, you can see that, right? And then weakness would be associated with that as well. But on the reverse side, on the extension, we would not be experiencing that, only when it is in the concentric motion, trying to prevent that concentric motion. So both pain and weakness on our concentric movements on muscle resisted range of motion. And just kind of as a side note, with muscle damage, the resisted and the active range of motion will always be the same answers. So for both resisted and active range of motion, when it's concerning the muscles, the concentric movement will both experience pain and experience weakness with that movement. So those were looking at muscle injuries. Next, we're going to take a look at ligament injuries. And we're going to start off with our active range of motion. So let's say we've got a ligament injury in our elbow right here, but we're still just trying to test to find out where this injury might be. So when we are looking at the concentric motion, yes, there will be pain associated with it. And that's going to actually be in both directions. Whenever there's any movement to that joint, there will be pain where that ligament is. Weakness, we will not feel weakness because it's not impacting the actual nerve or muscle. Weakness would only be because of the pain itself. And so it's not producing any difference in the force of the movement. So you will not see weakness when it comes to these movements, but you will see pain on the contraction and movement. So now with passive range of motion, the clinician is now going to be the one who is lifting and moving that elbow back and forth, right? And as they start to move it in different directions and moving it passively, what's going to end up happening is that, yes, they are going to experience pain whenever that motion is happening. So pain on the passive movement up and down. So now we're going to take lastly for the ligaments and look at that resisted range of motion. So now we are resisting the motion either in the flexion or extension while they are trying to perform it. And what we'll notice is that there's no pain and no weakness during resisted ranges of motion. When the ligament is the thing that is damaged, when it is not moving, there isn't pain associated with it. The pain comes when there's actual movement of the ligament, which is changing how the ligament is either stretched or not stretched, and any movement that's happening. And we will, again, not experience weakness because there's no force that's being produced by a ligament, only with muscles and with nerves. So this was with ligaments and the resisted range of motion. Now let's take a look at our nerves. We're going to start off with active range of motion, in which we are asking the person. And in this case, we've moved from a body part. We're actually down on the ankle right now, and we're going to do dorsiflexion and plantar flexion. And take a look here. So when we're looking at nerves, right, and we're still going to be looking at the concentric contractions from what we can see, nerves, because they are motor nerves and they are eliciting the movements, what we are going to see is a change in the weakness that we may have. So with the concentric movement, yes, there will be weakness. However, with a motor nerve, we're not going to be sensing the pain. So I want you to keep that in mind. These are motor nerves. So there's not pain associated with it. It's just weakness in that it is not able to contract as strongly with that contraction, with that concentric movement that they're doing. So next, we have the passive range of motion. So us now moving their foot in that dorsiflexion and plantar flexion. So when we're looking at our results of what this would look like, we are looking at no pain, right, during this concentric motion on either direction, the concentric or when it's returning back to normal or going in the reverse direction. And remember, with passive range of motions, we are not actually looking at weakness at all because there's no weakness that is told. There's no force that's being produced, right? So with nerve damage, we would find there was no pain on the concentric motion. And then with resisted range of motion, again, we're not going to have the pain, but when we're assessing for weakness, we will find weakness in those areas because the nerve transmission is being blocked because of the injury itself. It will not have as much force behind that contraction. So, in that concentric movement that we have, they will experience weakness, but we will not be seeing pain, which is different than what we saw with our muscles. Okay, so that summarizes it by the tissue type. Now we're going to go through it by our findings and try to work, kind of reverse engineer it to find out what exactly might be going on. So if we're looking at active range of motion and it is either weak or painful, right? So active range of motion is either weak or painful, the different things that it could be. It could be that the muscle that is contracting concentrically is injured. And for that to be true, it would need to be both weak and painful, right? So weak and painful indicates it's the muscle that is being concentrically contracted. Nerve that might be innervating the muscle could be damaged, which produces the movement, could be injured. And it would be weak, or sometimes what we term as like difficult. It's harder to do that, but there would be no pain associated with it. So, whereas with muscle, you had both weak and pain, the weakness and the pain. With a nerve, you would have weakness, but no pain associated with it because we're dealing with motor nerves. Now, as a side note, we do need to make sure that the muscle belly innervation has to be distal to the site of the nerve injury, but that would be the case in the examples that we're using for this particular course. If it was active range of motion was weak or painful, the ligament which crosses that joint could be injured, but it would not be weak, it would just be painful. So active or passive range of motion would cause the pain for the ligament being damaged. So with muscle, we're looking for that concentric movement is both weak and painful. With nerve damage, it would be weak but not painful. And with ligament damage, it would be painful but not weak. So that kind of gives us what's going on with our active range of motion testing. Now let's take a look at passive range of motion. Now remember, we're not looking at force, so there's no weakness that is going to come with passive range of motion, but we are looking at pain. So if there was pain upon passive range of motion of whatever it is that we're testing, It could be that the muscle that is being passively stretched during that movement is injured. So when it's going in the reverse direction of that concentric contraction, it could be painful. Or it could be a ligament that crosses that joint is injured, right? And we just talked about that in the previous example. For both active and passive, it would be painful. So that's if our passive range of motion is painful. Next, we have if our resisted range of motion is weak or painful, and we're going to find out which it is and how that applies to it. And remember, resisted is when we're doing this isometric contraction, when there isn't actually movement that's being produced, but just force is being produced. So it could be that the muscle that produces that movement is injured. And again, we would have weakness and pain both in that circumstance. It could be a nerve that is innervating that muscle that's being tested is injured, and it would present as being weak or difficult, but there would not be pain associated with it. And again, the muscle belly innervation has to be distal to the site of that nerve injury in order for that to be correct. So that's what we're going to see. We would not see any painfulness if it was a ligament. So you'll notice that is not listed here. Okay, so let's use this a little bit to talk about how we could actually approach questions like this. So here's another example of a more complex clinically based question. You're a ski patroller assigned to work in the terrain park for the afternoon. You witness a snowboarder take an awkward backwards fall on an outstretched hand with a slightly flexed elbow. While assessing her injury, the snowboarder indicates that there is pain when actively flexing and extending the elbow. Passive flexion and extension is painful too. Holding her elbow in a neutral, pain free position, isometric, resisted flexion and extension are performed, and she indicates there's no pain or weakness with the resisted range of motion testing. So the question is, which of the following is likely injured? And here's how I'm going to instruct you on how to approach these questions and how I find that this works for individuals. First thing, don't even look at the answers yet. Right now, we're just looking at the question itself, and we're going to try to figure out what we can do with this question itself. So first, we have to wade through all the excess extraneous information that we have. So for example, we have now bolded right here the important things that we need to take into consideration, and the other things are just added information that we can throw out of the question. Right? So we do know that there is pain when actively flexing and extending the elbow. Passive flexion and extension is painful, and resisted range of motion for flexion and extension have no pain or weakness. Right? So then what I like to do is I make a little note on the side and I say, okay, I've got active, passive, and resisted. Now, what is going on when I do these different types of a test? Well, with our active range of motion, both with flexion and extension, there's pain associated. With passive flexion and extension, we saw pain in both. With resisted flexion and extension, there was no pain and no weakness. So now, if I go back to those results findings that we just looked at a moment ago, when we have pain when there is movement of the joint, but it's not showing any weakness, when it is not when we are performing our resisted range of motion testing, that's already giving us a clue of what type of tissue might be the one that is injured. Now, hopefully you were able to come up with this too and look that it's got to be a ligament that is injured, right? Because we have pain when there is movement, both active and passive movement in either direction. However, the resisted range of motion produced no pain and no weakness, which indicates that that is a ligament. So now what I can do is I can go to my answers and start looking up. Right? And I look up in my answers and I see the triceps muscle, the biceps muscle, the ulnar collateral ligament, or the musculocutaneous nerve. Now, right off the bat, with this question, I already know my answer without even knowing what the ulnar collateral ligament does, but it's the only ligament that's actually listed here. But if I had another ligament that was listed here, I could then say, let's say it was instead the tibial collateral ligament instead of the musculocutaneous ligaments. And I had two different ligaments here. I would say, okay, how would I know which one it is? Well, one of them would be assigned to the elbow, and that's the movement that we're seeing right there was with the elbow, versus the tibial collateral ligament would be actually be if it was the knee that was causing pain. So it'd be testing my anatomy in that direction. So hopefully that makes a little bit of sense and gives you a framework in which we'll do it. Throughout class, we will be doing lots of questions that will build upon this and give us lots of practice to be able to really finely hone our skills to be able to determine what might be injured in these clinical scenarios. So I hope you enjoyed that. If you need to watch it again to follow along, please make sure that you do that.